Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's topic is Ascariasis or roundworm infection. If you like our channel, please consider subscribing it as well as share it to your near and dears to help them in their pursuit of a NEET PG seat. Also, don't forget to press the bell icon below to get my videos regularly. Ascariasis is caused by a nematode, Ascarislumbricoides, also known as roundworm. Its larvae cause pulmonary symptoms, while adult worms cause gastrointestinal, biliary, and pancreatic symptoms. It is the largest and the commonest intestinal nematode that infect humans. Disease transmission typically occurs through faecooral route. Younger children are most often affected. Infective eggs are transported on vegetables or fruits and are ingested. Adult worms live in the small intestine and females produce eggs which are passed with the feces. Ascarid eggs are very resistant to environmental factors and can remain infective for years. Ingested eggs release larvae that invade the intestinal mucosa, migrate to the liver via the portal system, and then through the systemic circulation reach the lungs. These larvae mature for 8 weeks and then break into the alveoli, ascend the bronchial tree, and return back through swallowing to the small intestine where they develop into adult worms. Sometimes the young adult worms migrate to the common bile duct or pancreatic duct also. The female worm produces eggs that are fertilized and thereafter excreted in the stool to complete the life cycle. About 9 to 12 days after egg ingestion, the larvae in the lungs may cause dry irritating cough, a burning substernal chest pain, dyspnea, and fever, known as eosinophilicpneumonitis or Loeffler syndrome. The adult worms in the small intestine usually cause no symptoms. In heavy infections, particularly in children, a large bolus of entangled worms can cause pain and sometimes a small bowel obstruction, perforation, intersusception, or volvulus. Perforation occurs due to pressure necrosis of the intestinal wall from a bolus of worms. Single worms may migrate into the common bile duct and may produce ascending cholangitis and obstructive jaundice. Acute pancreatitis may result from a worm in the pancreatic duct. A high index of suspicion is mandatory, otherwise the diagnosis may be missed. If a person from a tropical country or one who has recently traveled to an endemic area presents with pulmonary, gastrointestinal, hepatobiliary, or pancreatic symptoms, ascariasis should be suspected as a possible diagnosis. Most simple way to diagnose ascariasis is through microscopic detection of characteristic Ascaris eggs in stool samples. Polymerase chain reaction of DNA extracted from stool is used in research and some clinical settings. Examination of a sputum or bronchoscopic washings may show characteristic hexagonal charcot-laden crystals or the larvae. Charcot-laden crystals are the breakdown products of eosinophils and may be found in the feces and sputum of people with parasitic infections. There is an increase in the eosinophilic count, as with most parasitic infestations. Chest radiograph may reveal evidence of eosinophilic pneumonitis or Loeffler syndrome. There are rounded fluffy infiltrates a few millimeters to several centimeters in size. On a plain abdominal film or a contrast CT scan, and also on barium meal and follow-through, a ball of worms or freely living worms may be seen in the small bowel. A worm in the common bile duct or in the pancreatic duct may be seen on ultrasound. Magnetic resonance cholangiopancreatography or MRCP may detect an adult worm in the common bile duct in a patient presenting with features of obstructive jaundice. Ascaris should always be treated whenever suspected to prevent potentially serious complications. The lung infection is usually self-limiting and requires symptomatic treatment only. For intestinal disease, treatment with anti-helminthic drugs is started. Drug treatment may precipitate acute intestinal obstruction from a bolus of dead worms if there are many worms in the terminal ileum. Albendazole 400 mg once, mebendazole 100 mg twice daily for 3 days or 500 mg once, or ivermectin 150 to 200 microgram per kg once are most effective drugs. These are contraindicated in pregnancy. Partial or subacute intestinal obstruction should be managed with nasogastric suction, IV fluid administration, instillation of piperazine through the nasogastric tube, and hypertonic saline enemas. The hypertonic saline enema helps to disentangle the bolus of worms and also increases intestinal motility. But unresolved obstruction, strictures, gangrenous areas, or perforations require immediate surgical intervention. At operation for obstruction, the bolus of worms in the terminal ileum is milled through the ileocecal valve into the cecum and ascending colon for their natural passage in the stool. Enterotomy and removal of the worms may be done if the bowel wall is healthy. Rarely, in cases of perforation, the worms may be found lying free in the peritoneal cavity. Here it is safer to bring out the site of perforation as an ileostomy because the closure or an anastomosis may be at risk of breakdown from worm activity. Sometimes at operation, the actual diagnosis may turn out to be an acute appendicitis, a typhoid perforation, or a tuberculous stricture, and the presence of roundworms is an incidental finding. In these cases, surgery is done as per the primary pathology. Common bile duct or pancreatic duct obstruction from a roundworm is treated first by endoscopic removal. If this fails, laparoscopic or open exploration of the common bile duct is carried out, followed by cholecystectomy. A full course of antiparasitic treatment must be offered post-operatively after all surgical interventions.